So I am Dr. Ali Atif. I am a facial plastic surgeon practicing in Lucknow, and I'm going to talk to you about a very trending topic, that is thread lifts, a non-surgical procedure, so to say. So, okay, Dr. Pawar is not able to hear me. Can everybody else listen to me? Am I audible to everybody? Okay, so Dr. Pawar, might be some problem at your end. Okay, everybody in the comment box is saying yes. Okay, all right, so I'm going ahead. If there are any technical glitches, please check, because from my end there is nothing wrong. So yes, introducing you to a modality which probably you won't find in detail in the books, neither a lot of technicalities of it is explained anywhere. So please, I would urge everybody to have a paper and pen to note down certain things that, and see, it's just a disclaimer that before I start, I will tell you that I do not intend on writing a lot on the slides. I just like very few things on my slides. So you will be finding more of diagrammatic representations than written material. So try to jot down some important points. I have also kept certain notes with me, and I'm just sharing certain points here. So please make sure that you're carrying a pen and paper. So a thread lifting procedure is again a cosmetic procedure that lifts and realigns a sagging tissue while adding definition to facial contours by using threads. So to put things in perspective, so to put things in perspective, why are we doing threads in the first place? What kind of threads are we talking about? Why is this non-surgical, particularly non-surgical treatment now such a trending treatment modality? So to understand all of this, you must understand one thing, that why are we doing it? First of all, we are doing it to counteract facial aging. And this facial aging is basically a reflection of your current systemic health. It might be your chronological aging, but due to this current scenario, the sedentary lifestyle and all the habits that people have, this kind of an aging is seen much earlier than the chronological aging. So essentially, the science of aging I will be describing you according to a new classification, and that I'll be discussing later on. Just to put things to perspective, I want you to know that when a person ages, he ages in the form of a triangle, right? The superficial fat, it starts sagging down. In contrast, an attractive face or a young face has an inverted triangle with the base towards the temple and the apex towards the chin. So when we are talking about something non-surgical, why does the surgical anatomy is of any importance? So this is where I want to put some light. Okay, I'm zooming in the screen a little. I hope all of you can see the zoomed in screen. All right. So this is particularly a cross section, or a coronal section to be very precise, right? And this coronal section is basically defining a lot of structures. There are bony structures. If I just mark it for you, how does this work? Okay, just a moment. Just take a pen and draw. So here, this is the bone, basically the skull or the temporal bone. Over the temporal bone, you can find this muscle, which is temporalis muscle. Over the temporalis muscle, there is a fascia, all right, which is called the deep temporal fascia. Then there is another space between two fascias, which is called innominate fascia, over which there is a temporoparietal fascia. So what I'm trying to tell you that this anatomy, why does it hold importance in this particular procedure is that you will be playing around the fascias. So you will be basically venturing into these spaces. As long as you are superficial to the fascia, you are safe. But as you go down and you see, in case of the this particular area, you see there are certain structures present in between the fascia. So these structures, if you tend to use a wrong technique, you might injure these areas. Here you see a little structure here, this yellow thing. Zoom into your screen and you might see that this is the facial nerve. All right. So you don't want your patients to go back with some kind of a ptosis of the upper eyelid or some kind of a transient facial paralysis. So if we talk about the layers of skin, or let's talk about scalp first, because if you see, everything is in continuation in a face. So if you talk about the scalp, what are the layers that you know of? It is an acronym, and we all have studied in our anatomy lectures that S lies for skin, connective tissue, aponeurosis, loose connective tissue, and periosteum, right? That is how we define scalp. Then what about the skin? On the facial skin, we divide the facial skin into a similar breakdown. Skin consists of the superficial skin consists of the same skin that you have all over the body: dermis, epidermis, hypodermis. Then there is a layer of just below this skin. Just try to orient yourself that if we are going to, okay, just in case you're going to inject this area, what all structures would the needle will pass through, right? So to say, if I am going to inject somewhere here, see what kind of a structure I'm going to pass through, right? So first thing that I'm going to hit is the skin. Then I will be in the superficial fatty layer, like this layer. Okay. Then I will be towards a very important layer, which I want you to listen very carefully, which is called the SMAS layer, or the musculus aponeurotic system. So basically what happens in the body and what happens in the face is a little different, right? The structural anatomy of the rest of the body, everything, all the muscles are skeletal muscles, which are attaching the bone or the tendon to another bone or tendon. What happens on the face then? Face is different in the sense that here the fascia is modified into muscles of expression, right? So on your face, you will see muscles of facial expression, which help you, project your agony, pain, laughter, whatever expression you have. It helps you deliver those expressions. So here, there is no bony attachment as such. The muscles, they arise from the fascia, they get modified and they attach themselves to the skin. For example, if I'm smiling, so it is pulling the skin within and it is making me do this particular expression. Now, why am I talking about this? Is that the face is made up of facial muscles, which are supplied by the facial nerve, and also there is masseter temporalis, which also form a part of the face, but they are not the muscles of expression. They are the muscles of mastication supplied by the mandibular nerve. Now, when we talk about the skin, we pierce through the skin, right, and entered into the superficial fat, the first layer that you hit after pricking the skin is the superficial fatty layer. This you can say is somewhere near the hypodermis. It is correlated with the hypodermis, where what all structures are present? We have a lot of major blood vessels present there, right? So uh, this particular fatty area has several compartments. The superficial fatty layer has compartments also. Why are there compartments? Because if you see, there might be a medial cheek fat, but what is holding that fat? There are ligamentous capsules in which these fatty tissues are contained. So quickly moving on to these how do I clear all drawings? Okay, so okay, so this is exactly what I was telling you about, that there are just beneath the skin, there are fatty compartments which have, as you can read through, from the temple all the way to your lateral or orbit, to your cheek, to your mandible, there are compartments of fatty pockets which are made through uh, capsules of collagen. And as we age, we lose this particular collagen and we lose these pockets, and the face droops down. So this particular layer is again important to know, because when we do face lifting, we tend to lift it. And this particular fatty pocket is present just above the muscles, just above the superficial musculo-aponeurotic system, or the aponeurosis. Now, what is the good thing about aponeurosis? We might have studied a lot of anatomy back in the day, but did anybody tell you that when you frown or when you act surprised, this aponeurosis that I'm talking about, it pulls the muscles of the platysma. So very surprisingly, this aponeurosis that is present all over the face, it is connecting the frontalis muscle with the muscle here on the neck, platysma. So even if you concentrate, palpate, and contract this frontalis muscle like this, you will see a very slight movement of the platysma also. Isn't it very surprising that a muscle which is moving here is connecting through aponeurosis with a neck muscle, and on this movement, even the platysmal muscles are moving. So that means this is a system, and that is why it is called superficial musculo-aponeurotic system. So this system is continuous, right? It starts from the platysma, goes all the way to the zygomatic arch. So here I am pointing out the zygomatic arch because this is what divides the SMAS from the aponeurosis. It is essentially aponeurosis only, just that anything which is attached below the zygomatic arch is called the SMAS layer. What is it called? SMAS, SMAS, which stands for superficial musculo-aponeurotic. Okay, somebody has started drawing now. Aponeurotic system. Anyway, please don't draw. And when we continue above the zygomatic arch, this particular aponeurosis is called aponeurosis only, just that it is named after the muscle it is covering over the face. Which muscle is present here? This muscle. Clench it and see, you will find this is temporalis. So this particular aponeurotic system, when it is above the zygomatic arch and covers the temporalis muscle, it is called the deep temporal fascia or the superficial temporal fascia, right? It is no more called the SMAS layer, right? So why is this important? This mask layer is important because if you cut through, even if I cut through this whole skin and reflect this area, and I am above the mask layer, as in I am above the facial muscles of expression, then I am safe in the sense that there are no important nerves or major blood vessels there. So I am not bound to deprive the patient of any neuromuscular problem or any vascular anomaly. Okay, having talked so much about SMAS, you must be wondering why God gave us this particular, organ, this particular system. If you have ever bought a shirt, a new shirt or a new piece of clothing, you must have seen that they are very nicely folded, and there is a very transparent thin layer of uh, paper in between that folding. You must be thinking, why do they put that particular paper in between those nicely folded shirts? That is because this particular sheath, this particular paper prevents the sliding of clothes over each other. Rather than sliding over each other and getting creases and getting those wrinkles, it slides over that paper, right? As long as the paper is intact, it is not going to create any wrinkles on the shirt. Now, applying the same thing on the facial surgery or the facial applied anatomy, this particular mask layer, as long as it is tightly adhered to the underlying structures, that is the deep fat and the muscles, there won't be many wrinkles or sagging of the skin, right? As long as this mask layer is tightly adhered to the underlying muscular structures, there won't be any sagging. So in case there is any trouble with the musculature or the deep fatty pockets that I'm going to soon talk about, there will be a sagging of the mask layer as well. So what will happen? This particular fatty tissue along with the mask will droop. So I will end up having a jowl or a very prominent nasolabial fold, or drooping of my eyelid. This is what is going to happen, right? Now, when we talk about the next layer, I am going to connect all of these structures in a way that you will be able to understand. Okay, Galaxy A52 is not able to hear me. Am I still audible to everybody? Guys, can I have, yes, okay. So Galaxy A52, please, first of all, correct your name and become a person rather than a mobile phone. Okay. So the whole relevance of this mask layer is that there is a lot of musculature, and where there is much musculature and we're talking so much about the facial expressions, there are also nerves. And which nerves am I talking about here is the facial nerve, right? The facial nerve, as you know, pes anserinus, they pass through the parotid substance of the parotid gland, and then they have this pes anserinus pattern which passes over the zygomatic arch downwards the zygomatic arch. Now when I'm talking about the zygomatic arch and I'm telling you that the structures or the fascia that is lying below the zygomatic arch is called what? Is called SMAS, and above is called the superficial temporal fascia. So there are definitely structures underneath that we need to understand, right? All right. Zooming out, going to the next slide now. Okay. So now, did you see? I spoke so much about the superficial fat. Its Its clinical significance is the drooping and the aging, right? Beneath this superficial fat was mass layer or the superficial temporal layer. What is below that particular layer? Then comes this particular layer. Guys, please don't draw anything. It's very difficult to handle these technicalities. If you were in a live lecture, it would have been a very easy thing, but an online lecture is difficult. Okay, all right. So look at this. Now we are talking about, we have pierced a needle through my skin. Then I'm going all the way to the superficial fat. Then I pierce through the muscles of facial expression. Now where do I lie? I lie at the deep fat. Where do we find these deep fat? These deep fat are present over the medial regions and the lateral regions, and accordingly they are named, specifically named. And let me just pull it here. Yes. So retroorbicularis oculi fat. This muscle is called orbicularis oculi. Everybody knows. Retroorbicularis oculi. What does it mean? That means underneath the muscle, right? So underneath the muscle, there is a fat which is called roof, retroorbicularis oculi fat. Then again, talking about the orbit, there is again a suborbicularis oculi fat right here. Okay. Okay. Or then there is this deep medial cheek fat. Can anybody tell me which muscle is this? I'm sure you cannot tell me, but can you just type it down for me so that I know you are not sleeping? This muscle, anyone? Oh God, this is not masseter. This is not buccinator, guys. Come on. Rhizorius. Very nice. Alechnesi. No. See, guys, this muscle is arising from where? What is this structure? This is zygoma, right? So this is zygomaticus major. All right. Rhizorius go a little more deep. Okay, I'm clearing the drawings. So underneath this, there is a deep medial cheek fat. As you can see, underneath this muscle, there is a draw. Yeah. So hard to. Okay. So there's a deep medial cheek fat. This is lateral to the muscle, right? And the other zygomaticus minor, underneath that, there is a deep medial fat. So something which is towards the lateral head or the zygomaticus major is the lateral medial cheek fat. Something which is underneath the zygomaticus minor is the deep medial cheek fat. So imagine, if, why am I discussing this, is that till now you knew that if there is a drooping of the face from the superficial fat, the face will sag. But what happens with this particular fat that I'm talking about? When you lose the deep fat, you will start looking, very old, in the sense you will lose the volume. And you know what? When you do fillers, when you do fat transpositions, when you do anything to increase the volume, you are actually replenishing this fat. People have this idea that the fat is the culprit. But the problem is the fat actually that helps to maintain the volume. We have to replenish fat rather than removing the fat, right? So after this, underneath the parotid, there is a fascia, deep fascia in this region, and somebody who's telling me masseter is here, and this is buccinator, right? So from here, there is this parotid gland this side, and there is a parotid duct which passes through this buccal fat of pad. And once you lose this buccal fat of pad, you look like this. you lose this area, you know, which many of you must be thinking in the head what it is called, but then that is the sunken cheeks, right? All right, so moving on. Clear so far, everybody? Any queries? We'll be discussing your queries for sure at the end, right? So keep noting things down. I am definitely going to answer each problem that you have, right? Okay, so I'm again taking you back to this boring diagram, right? It looks very bad, I know, but then if you understand this, I'm sure everything, all injectables will become a cakewalk for you. Now follow me when I tell you that this, let me draw first for you. And should I change the pencil color to red or say red? So this muscle is the platysma, right? Do you see platysma is continuous with this blue thing going all the way up? See, we have been designed in such a manner that this particular fascia, it starts from the platysma. Now look at me, don't look at your screens, look at me. It starts from the platysma, right? And here, when it reaches the lower border of the mandible, it splits into two, right? The rule of two, I'll tell you what happens then. It splits into two, covers the masseter, right? Covers the parotid gland. And here it is called paratidomasseteric fascia. Again, do not confuse this with the SMAS layer. Why? SMAS layer is over the muscles of expression. Platysma is not a muscle of expression, right? It is an accessory muscle of, all right. So anyway, masseter is for mastication. All the muscles which assist in chewing are accessory muscles, right? So when I talk to you about the fascia, it splits into two, covers the masseter and parotid, goes all the way to the zygomatic arch. Here it again is called from here upwards superficial temporal fascia. It covers the temporalis fascia, goes all the way up, and here the aponeurosis of the scalp meets with this particular fascia, and hence this whole structure is called a system, right? This is what we are clear with till now. I am talking to you about things that are different from a SMAS layer when we come to deeper structures, like in case of temporalis. Now if you look at temporalis, it is different from this blue layer, right? Look at this layer and look at this layer, right? The superficial temporal dark blue, this dark blue line and this light blue line is the SMAS system. Underneath this, there is a space which is called, this is a space, basically it is called fascia, but this is a collagen fibers all around this place. This is not exactly a fascia, but to keep things simple, anatomists, they call this they call this layer as innominate fascia. Why is innominate fascia important? Because see, this is temporal region. So which blood vessels do you think will be there? Superficial temporal vessels. So these vessels lie in these innominate fascia. Underneath this is the temporalis muscle and the temporalis fascia. So we are clear with so many fascias and so much confusion that now there are two different fascias that we are concentrating, right? One is over the muscle, which are very tightly adhered, which is the cervical fascia, or you can call it according to the name and structure it is traversing on. If it is on the masseter, it is masseteric fascia, right? But over the masseteric fascia, there is a superficial musculoaponeurotic system which is SMAS. 99% of the people confuse both the layers. They think it is the same. It is not the same. Try and understand this, that SMAS layer is different from deep cervical facial layers, right? I will keep it till here, and I request all of you to please, after the lecture, pick up your book of anatomy and try giving it a quick read. Okay. So one thing is absolutely crystal clear now, that's mass layer and the deep cervical fascias over the different muscles are different structures. All important structures like nerves and vessels, they lie over the layer or under the layer. If I'm cutting through superficial skin, fat, and fascia, am I going to hit into any artery? No. Am I going to hit into any nerve? No. Everything which is important is underneath this fascia. This is clear, and I'm not expecting a lot of understanding of this, but I'm sure this much should have been clear by now. All right. So now that I've told you there is this fascia everywhere, why am I so hell bent on teaching you anatomy instead of threads? Is the reason that anything which is over this fascia, all over your face, and you're trying to basically put a thread, needle, or cannula inside the skin, or say, for example, even fillers or Botox, you are very susceptible to injure any structure which is traversing in an oblique fashion. So there is not a lot of things that passes obliquely on the face, but to name a few, these are the few anatomical structures that could be damaged during thread lifting. Now, in the starting, I also told you that the structure of the face of a young face is inverted triangle. That is a more pleasing structure to look at rather than a normal triangle which is sagging, which is a sagging face, compared to an inverted triangle. An inverted triangle, we believe, is more pleasing to look at, more aesthetic, right? Some comments on the chat box. Sir, please increase volume. Okay. Am I not loud enough? Dr. Narayana? Am I all right now, everybody? Am I audible? All right. Okay, I'll be more loud. Okay. So guys, now we are discussing about the anatomical structures which we might damage while putting the thread inside. First of all, you guys know what we're talking about, right? We know about the thread is a cannula which goes through the skin. Or you just thinking about some sewing thread. Okay, even if you don't, my idea of teaching you anatomy first is that I do not expect you to know about threads at all. I'm starting a refresher anatomy lecture in the first part of this session so that when we progress further in this lecture, we know about what layers we are talking about. And as a fellow, you are entitled to know all these things because these are not the things that you're going to find in regular anatomy books. I have catered to this particular data from well-researched articles which are pertaining to cosmetology. Okay, so please go back home, try and read something from your general anatomy books also. Okay, so then what are the blood vessels, nerves, and other structures that we are concentrating on? We are trying not to hit them. We're not trying to, create any kind of trouble to these particular, starting from the top to bottom, right? On the top, we have the superficial. Okay, let me zoom in a little for you, clear the points. All right, this superficial temporal, right? So superficial temporal starts from somewhere here. Okay, it goes under the, it is always under the muscle. I'm just trying to show you. It traverses anteriorly here, and a branch also goes back here, right? But I'm not telling you all the branches because when you do threads, you are somewhere in this area. You basically pierce through this area. Then you kind of put a thread here, right? And then you lift this area up, right? Imagine you're doing a non-surgical procedure. You've asked and convinced your patients that no, we are not going any surgical procedure on you, and you hit the superficial temporal artery. It is definitely going to create a hematoma, right? You don't want to do that, right? Next, another point that is important to know is the zygomatico orbital arteries, right? It is so easy to hit it because if you see, no, I'm not going to answer. I just want you guys, and I don't know, I can't hear you guys, but I just want you to, tell me when I'm asking you. This is, oh, sorry, let me clear all drawings. Let me take a pen. So this superficial layer is skin. This yellowish part is superficial fat. What is this, guys? Into the comment section. SMAS layer. See, nothing lies on the SMAS layer. As soon as we went down below the SMAS layer, what did we find? Zygomatico orbital artery, superficial temporal artery, right? A bunch of middle temporal veins, right? We found this transverse facial arteries. We found parotid duct, buccal branch, what not. Like you, as soon as you go and it is, let me tell you, when you do it surgically, it is not hard to go past the superficial SMAS layer, right? It is not hard. You can easily penetrate in. So you must know these are the no-go areas. These are the danger areas. You don't want to venture into these areas, right? All right. So we know about the veins. Now, as a rule, you know where do the arteries come from? Most of them are coming from the external carotid artery and, traversing all over the face from the external jugular, they're coming all the way up, right? Or the branches of subclavian artery are coming up. Now, where do the nerves come from? Nerves these are the cranial nerves. From this, they must be coming from inside the medial part, like the facial nerve is coming from the which foramen? Stylomastoid foramen, right? It drops down, runs medially to the styloid process, goes into the substance of parotid gland, so that is medial. So try and understand when we talk about injectables and we talk about nerves, the nerves are coming from within outwards, like they're coming from inside outwards, right? So there are there are chances of hitting the nerve directly are less. But when you're going for advanced thread lips, like you're going for a anchoring of the deep fascia rather than SMAS layer, you wanting to go further deep to the deep fascia, then you are actually playing with arteries, veins, and nerves, and the neurovascular and the parotid. Everything comes into picture. So when you go much deeper, there are temporal, zygomatic, and buccal branches, even marginal mandibular branches, which start from where? The anterior border of the masseter. Then superficial temporal is 18 millimeter ahead of the tragus, 37 millimeter ahead vertically. So I will, in the next series, next phase, I'm going to tell you exact millimeters where you will find these landmarks in most of the population. These studies as such are done on Caucasians, Koreans, and you can say more of Asians, not us, not the Southeast Asians, but the Caucasians, and hence the variability of anatomy can still take into account. But mostly what I'm going to teach you in the next session is going to give you a rough idea as to where these particular structures remain. Okay. So now imagine I am pinching this area of the zygomatic, or you can say temporoparietal region. This is temporo and parietal region. I'm going to pinch because this is exactly where my thread is going to go into. So when you pinch this area, there is a separation of the subcutaneous fat from the superficial temporal fascia, creating a gap between them, right? So if you look at this particular diagrammatic representation, such a beautiful diagram this is. So see, what I have been teaching you now is called pinch anatomy. I want you people to know that when you're pinching this area, what all structures are lying beneath these two fingers, right? To cut such a long story short, this is exactly what I want you to learn, right? Because when you're going to introduce a thread, what are you going to do? You're going to pinch this area. And if you are thorough, which particular layer you are pulling out, you will be sure you're not going to damage anything, right? So I'm going to use, I'm just going to clear this drawing, and I'm probably going to use an arrow. I think that is more understandable. So see, initial prick, I'm just telling you roughly, initial prick you have given almost vertical, right? You entered the fatty layer. Now you know if you go further straight, you're going to pierce through this layer. This, do you want this? You don't want this, right? So we remove this and we angulate. After entering this much, we angulate our needle this way, that we enter into this particular region without hitting any of these structures. We don't want to hit the superficial temporal. We don't want to hit the facial nerve. So we are going to angulate this. Okay? We are going to put an angulated needle and we are going to go past this area and hit somewhere here and then pull this area back. This is what we are going to do. It looks difficult, but trust me, once you are thorough with this concept, the next few slides will become a cakewalk for you. Okay, so after so many talks about everything, now let me tell you the basic definitions to start off with threads. So there are three particular things and a very basic things to know, about threads. And these three important things are fixing point, direction vector, and hanging points, right? So what is a fixing point? What are the criteria of a fixing point, right? As you know, I've already told you that the fascia that we're talking about is a very tightly adherent fascia. So we need a fixing point wherein there will be the forces of pull. So in this particular diagrammatic representation, this particular area is the fixing point, right? The direction, the next in the definition is direction. This is the vector of force or the vector of the thread that you're going to pass through the fixing point. So you made a small ditch here, made an 18 gauge, made by 18 gauge cannula, right? And entered a thread through this direction. You chose that you want to lift this particular area. So what will be the vector from the fixing point to this particular point? It will be this, right? This will be the vector. So this is the direction. Now, I spoke about this point. What do you think will be this point? This will be the hanging point, right? This is the hanging point. Hanging point is that point which you want to pull up, right? And how will you pull up? Through the vector of force, through the direction, through the fixed point. Now, I will like to give you a small example of bungee jumping, right? Many of you must have done that. If you jump from a bungee rope, bungee rope or a harness, you're wearing that harness, right? You jump down, there is a rope, and then there is a pole onto which that rope is attached. So this rope or this pole onto which the rope is attached is what? The fixing point. I am fixed here. I have a rope attached, right? And I jump down the platform. So there will be a force here. Just a moment. So there will be a force here, and this force will actually be fixed to something. So this will be fixed to this particular point, right? Now, after the direction vector, sorry for that interruption. Yes. Now, coming on to the direction, you are very sure about the directions also. Say, for example, let me see, I want to lift this particular nasolabial fold. This will remain the same, but the direction vector will change. It will be here. And this will be the hanging area or the hanging point. So it is not necessary that you reach to the depth of the hanging point. You can, okay, there are some comments. Okay, so Dr. Lakshya has asked us which plane are we aiming at? So yes, we are aiming at the SMAS layer. This is exactly what we were talking about. We are aiming the SMAS layer. But I was telling you beneath the SMAS layer because I don't want you to go into any kinds of complications. And there is another question regarding the complications. Guys, we are going to hit complications later. Just try to go with the flow, right? It's not a lot to go through. I'm just going to quickly rush through the classifications, right? So I was telling you about the hanging points. Hanging points as such, you do not require to reach all the way here. If say, for example, you want to lift this area, even if you go till this area, it is going to still pull it up. Why? Because all of this is connected through SMAS layer. So if you pull a SMAS layer from here, it is going to pull this area also. So I think we are clear about this, right? Guys? After everything, this is what I want you to quickly probably click a picture also. Okay. Okay. All right. So there is this classification from Fundaro et al. Right? Fundaro is basically a great researcher when it comes to aging. So he has a lot of publications on aging. So he studied some thousands of people on their pattern of aging, and then he divided all of them into 4 categories as mentioned here. Don't go by the types, just try to read about which type will you choose for which kind of thread lift, right? For example, if a patient walks in and his cheek appears to be absolutely flat or a little, concave, and these nasolabial folds and marionette lines appear because of, say, laxity of the tissue here, and there is a little sagging, right? And the jawline is a little sagged. So which muscles or which particular fat we are talking about is here, right? You look at the hypertrophy of superficial medial cheek fat. Remember we talked about medial cheek fat. See, superficial medial cheek fat we are talking about here, right? Somewhere I would say here, right? Somewhere here. Nasolabial fat would be somewhere here. Okay. So similarly to all of these, there are types. And then if you reach a particular stage, uh, okay. So you would reach a particular type 4 wherein you know that nothing except your surgical facelift is going to help you, right? So it is very necessary to start off early. See, the type 1 is something that, probably somebody by the age of 28 to 30 also will have on his face. You will see, there are marionette lines, or the cheek is appearing to be very flat or concave, or, there are sagging of the, you know, jawline is sagging, right? And the next stage is also very, very transitional, wherein the infraorbital area is also having a compartment. There is a little bit of ptosis here and there. So this is how you define a particular patient. This is how you look at the patient, and this is a clinical classification, so to say. This is not like, it is not helping you out in any way otherwise also, but then you know which kind of a type a particular patient is belonging to. You should know the type 1 and the type 4. Why? Because these are the starts and ends. In middle you can play around. Say if there is a type 3 or type 2, would you like to club up with other things? Yes, you would like to do some botox, you would like to do some fillers where there is loss of volume, so much fat is getting lost, you might to add on some volume. Where there is some thread lifting is required, you do some thread lifting. Where there are some crow feet, you would like to do botox. So for type 2 and type 3 you can have an intersection of a lot of things. Type 1 again you can do by very minor, thread lifting or very minor botox. So this holds true with a lot of things. If you're going on to the type 4, then probably again all of these things plus surgical. I think we are good with this. We are good with this, right? Now, finally coming on to the topic, which is the type of threads, right? The type of threads can be divided into three main categories. This is based on their characteristics. Okay, so this this is based on the mode of absorption, whether these are resorbable or non-resorbable. There are barbed or non-barbed, or the length of the threads. So basically what I want to tell you is, how many of you have used resorbable sutures in your practice? There must be some dermats, plastic surgeons, dentists, allied medical fields. So you must have used that particular resorbable suture called Vicryl. So to put things into perspective, it is more or less like a Vicryl suture. The material that I'm talking to you about. So it might be a resorbable, or it might be something like Prolene. I don't know if you have seen polypropylene sutures. These are these blue sutures. It might be non-resorbable threads also. So these are the two types. Barbed or non-barbed means, see, there might be a smooth wire, a smooth thread, just like your hair, right? It is a smooth thread, or there might be spikes protruding out of them, or barbs. That is called barbed or non-barbed. So there might be small length threads, very tiny threads for small indications like, scars, or you can say vermilion border of the lip, or the cupid's bow accentuation, or NLBs, nasolabial fats, nasolabial creases. Or there might be longer threads, like more than 90 millimeters in length, which are used for facelifts. So these are the type of threads that are available in the market. So there are generations. Today we stand proudly in a golden era. It all started, if I tell you very interestingly, initially there was no concept of threads. Initially in the 90s, 1918s, the first case of facelift was reported in 1918, somewhere in the First World War zone. So imagine, we have gone through multiple world wars, first and second world wars. We have faced a pandemic, and right now, thankfully, we are in an area wherein a lot of great results can be achieved by these diverse, multi-generic threads. So starting from the first thread, you can see it's a thin mono thread. It's a thin, smooth thread, right? Not much of a lifting can be achieved from it, but okay, it all the threads in its quality, its quality is to create a new collagen. So it is for collagenesis. It increases the collagen, mainly type 1. When we go for, and this is true for polydioxanone threads or the PDO thread, also known as PDS thread. We will be coming to that. When we talk about PLLA threads, there is a formation of type 1 and type 3 collagen, even better, right? We will quickly discuss that. So I'm just trying to tell you these are the 4 generations. You can quickly click a picture or a screenshot. So if something is spiral, what is it doing? It is increasing the surface area by becoming spiral. Third generation has cutting threads with cogs. What do you think is it important for? You've seen a barbed wire, a barbed wire, if you pull across your skin, it is going to hook through the mask layer and going to pull it. Fourth generation will be bidirectional. So see, what is a bidirectional or a unidirectional? Okay. Sorry, where were we? Where were we? Okay. Yeah. So unidirectional, if you can see, it is going into one directions. Bidirectional will be on both sides. So it will be going one direction to the left and one to the right. So essentially, once you introduce a bi-directional thread, it is going to hook on to both sides and it cannot move any. Unidirectional barbed wire has its advantage into the sense that when you're going to introduce it, it is going to hook onto the skin. But if you don't like that particular look on the face of the patient, if you don't like it, you can still have some, leeway to correct that. With a bidirectional, this leeway is not there. Once done is done. If you like it or you don't like it, you have to be satisfied with it. So now this is how I am zooming in. This is how a thread looks like, pretty much like a needle that you use, but this portion is called a herb. This should I do? Let me just, okay. So all right. So this particular area is called herb, not hub. Herb. That's what I also thought. It is called a hub, but it is herb. And from this herb, there is this metal cannula kind of a thing, right? Which is blunt here. On the top, it is blunt. And this is the thread which passes through this area along with this stopper, right? This goes straight. See, this is what this slide we saw earlier, right? This slide we saw earlier. And what happens here? Now tell me, what point is this? It starts with an F. What point, what direction is this? This is, okay, sorry. This is the direction vector, and the last one is the hanging point. So I have tried to simulate what it exactly looks like. Okay, fixing point. Very nice. So nobody's sleeping. I'm glad. Okay. So you introduce this cannula through an entry here, right? And because this is blunt and you have studied so much about SMAS, you will be probably superficial to the SMAS. That is what I pray. And when it goes, it slides down inside, reaches the hanging point, and see these barbs, these guys. Look at these barbs. What do? They hook onto the SMAS layer. And SMAS layer is hooked onto what? SMAS layer is hooked onto the underlying deep fat and muscles. So when it pulls up everything with it. Great. So again, coming on to the non-barbed threads, this is how a non-barbed thread look like. It's a mono PDO thread, right? It's very thin, almost thinner than your hair, and The function that I have told you, it is more or less for the creation of collagen, right? Now, cog threads, what is cog? What is PDO? What is mono? So as it is, I've told you, I'm just showing you the types, but what falls into what category, it will be clearer with the classification. I'll show you that classification also. Just try to understand the terminologies, because once you enter the market, you will be talking about, anybody will ask you, you're going to use a mono thread or a cog thread. So understand, a mono thread does not have these cogs or these spurs, so to say. It does not have these spikes. And a cog thread would have these spikes. These spikes, again, if somebody asks what kind of cog thread, then you can say, I'm using a unidirectional. Like a pro, you can tell them, I'm using a unidirectional. Or when you attain a little bit of more mastery over threads, you can say, I am very, very thorough with threads. I'm using a bidirectional cog thread. So this is how it works around. So now coming on to the screw threads, again, it does not have any cogs. It does not have any barbs. It is just a spiral thread just to increase the surface area, right? A straighter mono thread would definitely have lesser surface area. That I think all of us will agree, right? Then again, a spiral thread. See, a spiral thread again will try to capture as much mass as it can, right? So it is a little bit of spiraling. So some cork threads will be on this surface, some will be on this surface, some will be on the, so to say, the barbs wire will be 360-degree present. So wherever you are traversing through in the mass layer, it is going to hook onto something or the other. Sometimes it will hook onto fat, sometimes to the muscle, sometimes to the mass layer. So this is the advantage. Okay, embossing PDO. Embossing PDO is nothing but just a manufacturer, so to say, modification, wherein there are indentations like this. See, so for example, you have a thread like this, and I do an embossing. I cut this area and continue. So won't you have this sharp angle here? So this is what an embossed PDO looks like. So this is sharp, it holds on to the mask layer. That's what it does. Again, already discussed with you. These are again different kinds and different types. Okay. Different companies like Aptos, Silot, polypropylene. Okay. PGA is polyglycolide. These are pure gold threads, not really used these days. We are very happy with PDO and PLLA threads. So that is exactly what we do. So what are the modes of absorption? Absorbable threads, they include polydioxone threads or the PDO threads. I'm not going into very much details into the brands and other types of things, but just try to know one or two names of it. Like Sculptra is a soft thread, a very popular thread of UK. In UK, it is very commonly used. PDO threads are readily available in all the markets, right? They have basically these absorbable cones. So these have cones one over the other. Rather than those barbs, they have cones. So what does the cones do? They grab onto the, so this is one cone, this is another cone, this is another cone. So now if you are going to pull it this way, and here there is skin, oh God. Here there is skin, it is going to get hooked onto this. This is what it does. Okay, so non-absorbable threads are Aptos threads, contour threads, or Silot left threads, waffles thread. Just for your, it's a trivia question. If you know a non-absorbable thread, great for you. So I think I must tell you, a PDO thread lasts anywhere to 6 months, right? Like, just in case you don't remember this, imagine if you don't pado, you're going to get a supply of 6 months. So you will remember PDO. PLLA is mostly 12 to 12 to 24 months, right? And then there is, by the way, PLLA starts for L-lactic acid, right? It is a material. It is more or less like PDO only, in the sense that it is also a resorbable material, but just that it will take much more time than PDO to resorb. And then there is a plane without the L portion. It is the PLA thread, which lasts more than 2 years. Now, anything which is lasting more than 2 years, it is going to create collagen, which is enough to hold on to the particular lift even after the thread has resolved. But earlier, these polypropylene threads were used, which are non-resorbable. And imagine somebody who doesn't like that lift and it remains there all their life. How awkward would it be? So there are indications for non-absorbable threads as well, but mostly we prefer going for absorbable ones. So look, such a great thing, histological study this guy did. So these Caucasian researchers, they researched so deeply into everything. So they studied this PDO thread. They thought, why only PDO is such a hyped, material for it. So they studied this particular segment in a cut section of a histology, and after doing these PDO threads, they studied what was the change. So they could see these 5 particular great changes after the PDO thread was introduced. Now, PDO thread, mono, barbed, non-barbed, doesn't matter. I'm just talking about PDO threads. Forget about barbed or non-barbed, whatever. It is going to create what? It is going to develop new fibrous connective tissue, right? I already told you that type 1 collagen, it boosts type 1 collagen. It merges the existing fibrous connective tissue. It merges with them. Okay, it becomes a part of it. Then there will be another myofibrin system, or the myofibroblast, which will be activated, and there will be tissue contracture also. So what happens when you get a wound on your knee? When it passes on to 2 to 3 days, you tend to have that contracture pain. Exactly what it does here, the PDO threads, it tries to contract the skin, further causing the secondary benefits of facelifting. Third, they will cause increase in the capillary vessel size. Why? The question is why? Because it is again an external thing which you are introducing to the body. So there will be an inflammatory response to it, and whenever there will be an inflammatory response, there will be a vasodilation, and it stays there. The capillary vessel size increases, and be very suspicious to the PDO thread lying next to you. Does not react, but it is very anxious. So once the capillary action is capillary vessel size is increased, again there is more neovascularization, more plumpier looking skin. And again, the next thing is fat cell denaturation. Of course, when so much of things, fibroblasts and myofibroblast and blood vessels are there, so it will cause denaturation of fat cells. So understand, I'm not talking about the de novo fat lipolysis. Like, we are talking about any new fat cells that have created over the period of time. That is not good for the facial structure, right? So it causes excessive fat cell that is present inside. It causes denaturation of that particular fat cell, again giving it a good form and function to the skin. Okay, so Dr. Radhika asks me that with absorbable threads, patients will have to undergo procedure repeatedly. So, Dr. Radhika, I've told you that this is a period of 6 months. Minimum 6 months it will take to get absorbed. And after getting absorbed, these are the 5 great things it is doing. So what happens now, that say you have achieved a facelift of, I'm just putting a random number to it, there are no numbers, I'm just saying, say for example, you gave your patient a 10 millimeter facelift. There is nothing like this, I'm just trying to explain you. You gave a 10 millimeter facelift to a patient. After 6 months, it might just stay there as 8 millimeter. even though your PDO thread has resolved. Why? Because it is already creating so much collagen naturally that it might just hold it for you. But again, that is depending on the classification of aging. If you're lying somewhere on type 3 and type 4, then sorry, then even after 6 months it is going to droop down again. You will definitely require another thread session, right? Okay, so let's move to the next. So see, I have purposely put this filled up slide for people who have, an OCD for written material. Please click a picture. This is exactly what I have told you so far, but just for your, you know, satisfaction, I have written down some, and we are almost ending. So you can just click a picture and see whatever I've told you. It's all mentioned here, right? Okay. Please excuse me for a second. Okay. Okay, soon after thread lifting, Dr. Ashwini is asking, there is change in the face or takes some time. So the lifting happens almost immediately. That is the beauty of it. The first day, the lifting is the best, But usually, what I practice is that after, see, these are only barbed hooks, and the whole assembly of our face is what so dynamic. We keep on speaking, we keep on eating. You cannot ask the patient to stop chewing because you have placed a cork thread inside. So what happens is you tape that area after you've placed say a PDO cork thread or anything. You just tape that area so that there is a passive pull also, so that the cogs or the barb threads are entangled into this mass layer. So the result is almost on table, but there it takes almost a 2 week to 3 week time period to start that fibrotic changes that start happening, that take almost 21 to a month. And of course there is a relapse. There is nothing in this world which can hold the skin against gravity. Just by a single thread you cannot do that, right? Even surgical facelifts cannot do that. So there will be a relapse, but definitely you can click a real-time picture of half of the face. You lift that area, click a picture, and then show that to patients. See, this is your undone side, and this is where the I've already placed the threads. It will be remarkably different. Remarkably different. If a patient has thread lifting once, that means the collagen will be in place. Will be in place, and if she decides to have it again, when we redo it, will we have any certain problem doing it? Maybe some tissue resistance? No, not really, not really. So of course, once you have ventured into uh, an area, there will surely be some resistance for sure, right? So just a second. Dr. Achal, I am sorry that you could not listen to me for the first 20 minutes, but then we'll probably have the discussion again in the next class. We cannot start off the beginning again, right? Uh, okay. So keloid, somebody asked me about keloid tendency patients. Please, keloid tendency patients, if you find any kind of keloid tendency or hypertrophic scar formation anywhere, always take that. I have not right now, it's just the beginning of my lecture, so I have not told you how to interact with the patient selection. I have not told you. I will read about this also. I have a slide about this keloids and other skin issues. Never, don't do it. You don't want to create a keloid here. Imagine, you will be world famous if you do that. Okay, so we were here, right? Again, on the length of threads, you can also classify short suture or long suture, greater than 90 mm or less than 90 mm, right? That defines if it is 90 mm or lesser, it is a short suture. Greater than 90 mm, it is a long suture. So imagine this is the end of part one, guys, and I hope you have a little idea about threads, and we will show threads and smarts relationship in a schematic diagram. Very nice. This is Dr. Shiakat Saha. Excellent. This is exactly what I'm going to show you next, right, in the next class. Right now, we are towards the end. If hematoma forms during the procedure, should the procedure be continued and how the hematoma be cured? So, see, if there is a hematoma formation immediately, you don't want to mess around there. You remove the thread. You do some pressure, cold compressions to remove to prevent any further hematoma formation, because as you know, the good part about the aponeurosis connecting your frontal muscle with the platysmal muscle is that it gives you a form. But the bad part is if a hematoma happens on your forehead, you get a black eye, right? So do not, in at this nascent stage, I will not recommend you to go further. If you encounter a hematoma usually visible in a very light skinned person, right? Can we do a double chin thread lift and masseter botox the same day, or should we give a gap of some days? Okay, there is a particular publication which talks about multidisciplinary approach for facial rejuvenation. I will bring that in the next lecture, wherein there is a proper guideline that, see, if you do, even that is given. If you do a mono thread, then wait for 2 weeks, then do Botox. Then if you are doing a Botox first, then you have to wait for 4 weeks to do a thread. So that's a properly studied article. We'll be able to discuss that. Dr. Sudharani is not able to hear me. Is it? So discoloration of hematoma can be cured by using, see, if a hematoma does occur, understand that there is some blood which is in a facial plane between some muscular layer, or between, you're probably gone deeper. So it has high chances to get infected. Start off with an antibiotic, okay? And along with it, you also understand that hematoma might in fact cause pus formation. So you do not want a thread making a tract of infection. Somebody asked me what to do when hematoma happens. If you are new to this, please stop the procedure. Start with an antibiotic. There is an ointment by the name of thrombophobe, which has heparin, which kind of helps over superficial hematoma or ecchymosis that happens over the skin, but it usually resolves over a period of 2 to 4 weeks. So don't worry about it. It's not a big deal. Hematomas you will keep on encountering, even in your injectables. So don't worry about it. So somebody is also asking me, can you please show us the earlier slides? Dr. Pragya Shetty. So Dr. Pragya, which slide do you want? Okay, Dr. Pragya, second slide. Okay. Okay, second slide. Just give me a second, Dr. Pragya. This is the second slide. Why do you want this slide? This slide. Okay, you want this, I'm sure, right? This is the one you're talking about, Dr. Pragya? Guys, keep pouring your questions. We are running out of time, right? It's almost 1.5 hours. No question, guys? Are we done? Just the previous one. Dr. Pragya, tell me what is there. Is it safe to do this one? Thread lift in. Introduction. Okay, here. Okay, thread left in diabetic. Can we do the anatomy again in the next class? We will definitely rush through it. Contraindications for any, invasive procedure. If he has uncontrolled diabetes, you have some other like keloids or any other condition, please imagine, understand we are doing a cosmetology procedure. We have to rule this out. We have to do proper blood investigations done. We have to do proper asepsis before introducing a thread inside. You are creating a tract of infection. How many dangerous things that I told you about: superficial temporal transverse, angular arteries, what not, parotid. You don't want infection to seep in from the temple towards the face and get into the danger area of the face, and patient ends up in cavernous sinus thrombosis by just you wanting to make patient beautiful. Please understand. Okay, is it painful? Very nice question, Dr. Reena. We are going to discuss about it. We have just discussed the basics. We are just diving into it. I'm just making you guys accustomed to it, right? Hello, sir. Can you please share us all the slides too? I'm really sorry. I'm really sorry, Dr. Devika. These slides are prepared after you won't even believe how much we study and how much we research. The whole idea is to give you a thorough knowledge about everything. I have literally nothing written on the slides. I have literally explained you everything. Okay. Sir, which nerve blocks are given? See, nerve blocks, again, it's a clinical site. We are right now we have not even done the pre-operative examination, doctor. We have not even done that. Why are you going towards injection? Any medications after procedure? Yes, good question again. See, we can give them a pre-operative antibiotic and post-operative antibiotic. Anti-inflammatories I do not prescribe, because that is exactly what I want, right? I want patients to have inflammation so that there is collagen formation. Okay, any medication procedure, can you enumerate some investigations? Same, Dr. Deepansh. Uh, everything is similar. There is no rocket science in this. CBC, BTCT, INR, you definitely want to know. If the patient is alcoholic, you want to go in for LFTs, right? Polydioxone is going to anyway pass through your normal pharmacokinetics and pharmacodynamics, right? It's a resolvable stuff. So you obviously not going to put threads into somebody who has a renal failure, right? So it's a pretty sorted thing, nothing to worry about. Just BTCT INR, I would definitely want to know. I would want to know if the patient is on any kind of antiplatelets. I would like to know if the patient is a heavy drinker, because that will again cause a blood thinning effect, all that kind of stuff. Will it not leave a scar when introducing? Yes, nice question again. So these entry wounds are very, a very small entry wound is made. Just like when a mosquito bites you, it does not necessarily leaves a scar. It is very aesthetically given, guys. You can even use a 15 number blade. You can always use a 11 number blade. Usually 18 gauge needle is used. So because it gives you a very nice entry, and you tend to do this fanning motion so that you release that SMAS layer from the fat layer, right? If, sir, there will be any lymph block or secondary swelling post procedure, it might, if you go so deep that you hit the lymphatic channels, then it might cause some kind of occlusion. But with so much training, I'm sure it's not going to happen. And even though, see, lymphatics are very dynamic in the sense they rechannelize themselves, right? You're not blocking anything, you're not ligating anything, you are going along the lymphatic channels, understand, right? Sir, once repeat about the type of threads and insertion of threads. Insertion of threads and type of threads we'll talk again in the next lecture, Dr. Reddy. Dr. Monica Reddy will do it again. Can't I get a chance to listen to your... Okay, Dr. Reddy, we'll do it. How to convince or prepare a patient for treatment, Dr. Reena? We'll do it. Don't worry. We'll do that also for you, right? Any other question? Guys, I will ask you question on SMAS. Are you better be prepared next time? Right. I want you guys to read SMAS. And any question? Am I missing anybody's question? Everybody is done here. I'm sure a lot must have already left. But anybody who is still here, you're welcome, Dr. Isha. Thank you, Dr. Tehmina. Okay. Any questions, please? Please ask me, guys. I'm here for you. You can ask me. You can still ask me. We have gone beyond the timings by half an hour. So I want you guys to indications of non-absorbable sutures is that when you want, there is patient is somewhere around type 3 to type 4 skin types, right? Aging types. And if the thread you are using PLLA, which lasts for even 2 years. You know that even 2 years is not sufficient for this particular person to actually have that kind of an effect. So you go in for a polypropylene or the non-resorbable threads, so that you know that by the end, like if it is non-resorbable, you can use it for an indefinite time. Probably couple it up with a mixture of a non-resorbable and resorbable sutures with PDOs. You can with threads. I am sure you guys are going to love it when you're going to practice it. You can do so much with threads, so much you cannot even imagine. I personally, it's my personal favorite after Botox. Of course, Botox is my favorite, but then after that, there's nothing which beats threads. What type of suture in what condition, what indication? So Dr. Kyra Sani, what type of suture are we talking about, and what is the age criteria for threads? Dr. Tamanna, there is no age criteria. I have told you the types. So the types is not constrained to age. If you see the classification that I've shared with you, so there is nothing mentioned about the age of the patient. So imagine if there is a 28-year-old guy with a type 2 aging, then wouldn't you go in for these threads? So age is not exactly a criteria. You want probably to know what is the minimum age one should go with it. Definitely somebody who should be able to give you his consent. I would consider that. I would not go in for somebody who is less than 18 years. But anybody who has this kind of trouble, who has it, also works great for your, scars. Small little video threads can be used for your neck lifts, your acne scars. A lot of indications. We'll read about that. A lot of indications. How can you decide which thread is best for which skin type? Which type of skin, by which type of skin you want to know the Fitzpatrick scale of skin, or you want to know the type of aging that we have discussed? Dr. Richa Tripathi, which one? Patient has Botox 3 months ago, want a thread lift done. You can easily go in for Botox, for thread lift. What things should we be careful about or know about? So the great thing about Botox is that your muscle is already in a flaccid paralysis. Now you're giving it an additional support, and it is an additional support by threads. So on that relaxed muscle, now what will happen? The SMAS layer is going to jump onto that muscle, and it is going to get fibrosed over there. So it is going to give you a double benefit, but not necessarily required in every case, right? But definitely it is of advantage, Dr. Somal. Can you please repeat the classification of skin aging? Dr. Suhasini, I had asked you to click a picture. It's such a boring thing to go back to classification. I'll give it to you next class, please. Or somebody share it with Dr. Suhasini if somebody has clicked it. It was very educational. Please read Dr. Kalpesh. It will be inspirational if you read. I'll be very happy. Dr. Srishti, please repeat medication in case of him. Any antibiotic. Usually we prescribe Augmentin 625 BD. You can also give anything to cover aerobes and anaerobes like ofloxacin. It helps for Bell's palsy or not. Botox fillers are applicable. So to maintain the symmetry, see if what happens with this facial paralysis, that on one side there is a basically the balance, you lose the balance of muscles. So the muscles shift to the affected side, right? So basically, if you want to balance that, you can give Botox onto the other side, but particularly, I wouldn't say that just Botox or fillers will work. I think you can go and do threads also. Dr. Shri Ramoju. Guys, these clinical questions, no, these are for the next class, guys. We will wind it in 3 classes. I've broken this down so that you guys understand this better. So clinical questions can come later. Tell me about these initial questions if you have. So moderators, I think we are done here. There are no more questions. We'll wind it up from here, guys. How will the thread hold? Come on, Dr. Monica, we were studying so much. The thread will, see, you are introducing it from skin, then going to the superficial fat, and then entering the SMAS layer. So the SMAS layer, when the thread you're using is a barbed thread, it is going to hook onto that SMAS layer. Under the SMAS layer, there is muscles, there is deep fat, there is fascia. So if you're going to pull SMAS, right, then it is going to automatically pull up everything which is drooping down. So that is how you attach the cogs or the barbed wires to the SMAS layer. That is how it will hold. How will the thread hold? Okay, I hope I am answering that, Dr. Reddy. 3 people have raised their hands. No worries, Dr. Reddy. It's okay. And people who have raised hands, any questions, guys? Please type them down for me. 2 participants raised hands. So these are Kalpesh and Zaha. Dr. Kalpesh, Dr. Zaha, anything you want to ask? Dr. Kalpesh is disappeared. Dr. Zaha? And guys, one more request. Please put your names, right? It is very hard to, call 557-568 Oppo. Please, guys, please have some, maintain some decorum. You are becoming a fellow here, right? Have some decorum, be proud of your names. And I want your names here next time. I will not allow anybody absolutely with, without names. So guys, we are winding up now. Types of thread slide. Dr. Dhana, we will come back to it. Again, we will quickly rush through, just that I will not enter very deeply into the this thing, anatomy. But guys, please go back and read. My humble request to you. Otherwise, you will never understand threads. I'm telling you, the next few classes are going to be amazing if you go back and read about SMAS layer and anatomy. Right? Basics of it. Please go back and read it. Read your notes. You have any trouble, I am always here. Okay. I've already shared a slide where everything is given, right? You guys can contact me there or ask directly to eliminate your supervisors. I will get your questions, answer them. Is there any indication to thread cross smash layer? Of course there are. You want to ask Dr. Ashwini, if you cross beyond this smash layer, it is not smash layer, it is smash layer, SMAS. Okay, I want a full form from you, Dr. Ashwini. So if you cross the smash layer, there are indications, and there are definite indications. We do go beyond the smash layer at times as well, but we are beginning, we are not going for advanced thread lifts right now, right? Advanced thread lifts is a different topic altogether. You're welcome, Dr. Pragya. So we'll call it a day, guys. Have a great night, and I hope you guys loved it. I really enjoyed your questions. Please keep pouring in your questions. You missed the beginning of class, Dr. Rachel. I understood. I will tell you about the SMAS layer again next time in short. You will get a hang of it. Meanwhile, try to read it from Gray's Anatomy, right? Or further anatomy. You guys, one more thing. Go back to Google, type PubMed, open PubMed, type SMAS layer, you can read that all your life, it will not end. There is so much data on SMAS, right? Just go on PubMed and type SMAS plus face. You will get endless data on it, right? Okay, Dr. Achal, hope that answers the question. Okay, guys. Moderators, I'll be logging out of the this. I'm stopping the slides now. You're welcome, Dr. Reddy. Who's typing sir here? Okay, bye bye.